Okay, thanks very much. I think we'll get started. I'm going to talk a little bit about colorectal cancer today. I'm Farah Din and a consultant surgeon at the Western General Hospital in Edinburgh. Just very quickly thinking about the role of surgery and surgeons in colorectal cancer management. And this really tries to show us that surgery remains central to colorectal cancer management at really sort of every stage, from thinking about screening, diagnosis, staging of disease, thinking about prophylactic surgery, reconstruction, and is really the mainstay of primary treatment of disease. And surgery also plays a role in palliation of colorectal cancer. And so we'll try and touch upon all of these over the next 20 minutes. So firstly, thinking about the epidemiology of colorectal cancer disease, in the UK, we know that there are around 42,000 cases of colorectal cancer annually, and it is the third most common cancer in the UK. The lifetime risk is around 1 in 15 for men and around 1 in 18 for females. So being a male is a risk factor. And if we think about prevalence and the projections, and this shows projections from the WHO from 2018 to 2040, we can see that there is an increase in colorectal cancer worldwide that is projected. And this is largely due to changes in the population. And these are data from the Scottish registry data, and we can see in terms of the population, we can see that as we go from 2016, which is where the solid line is, to the other solid line, in 2035, we can see that actually there is a shift in terms of a greater population. And this really just emphasizes that, again, age is a risk factor for colorectal cancer. And we can see from our own local data in Edinburgh that we operate on roughly around, we see roughly around 550 cancers a year annually. And these are the 2020 numbers, which we can see are somewhat depleted due to the recent pandemic. Now, if we look at colorectal cancer mortality, we can see that it forms around 10% of all deaths. And we can see that the trend over time has been that there has been a decrease in mortality. And this has largely been due to improvements in perioperative care and post-operative care and better patient selection. If we look at the mortality projections, again, around the UK, what we can see is that going up to 2035, and these are data from CRUK, we can see that there will be a decrease in mortality from colorectal cancer. So that's all good news. But if we look around worldwide, what we can see is that where in countries such as the UK or Australia, or New Zealand, there has been a relative stabilization or decrease in the incidence of colorectal cancer. We can see that in those countries where there has been an increase in economic growth and an increase in westernization, we can see that there is indeed an increase in the rate of colorectal cancer. And that gets us thinking about the etiology of the disease, or the cause of the disease. And these are largely two: genetic and environmental factors. If we think about the heritability of colorectal cancer, so this is the proportion of phenotypic variants that is attributable to genetics or genetic variants, we can see that from these twin studies by Liechtenstein, we can see that up to 35% of colorectal cancer is thought to have a heritable or a genetic component. Here, what you can see in red is that, in fact, all we know about colorectal cancer in terms of the defined genetic variants, in fact, makes up under 3%. So there is a large heritable component that we are yet to still discover and make advances in terms of research. And if we then think about some, and I'm not going to talk about the genetics of colorectal cancer today, but just briefly to mention some of these syndromes that make up that 3%. We can see here that we've got autosomal dominant syndromes and autosomal recessive syndromes. And again, the main thing just to focus on is that the contribution to colorectal cancer is indeed quite small in these syndromes individually. The main two being Lynch syndrome and FAP, which I'll talk about just in the context of cancer development. So the mainstay of the etiology comes from environmental causes, and this means that around 54% of colorectal cancer is in fact preventable, and we should perhaps be targeting some of our focus on preventing the disease. So things that we know is that it's caused by a lack of fiber in the diet, caused by eating diets that are high in red meat, and an increasing association which is found with obesity and physical inactivity. Why is it important that we actually think about trying to understand the population risk of colorectal cancer? And so if we think about the population as a whole here, we know that the general population is at average risk with those numbers that I showed you earlier, with a 7% and a 6% lifetime risk. And then we can also think about these familial settings where in fact there may be some genetic variants or genetic defects that result in people and patients being at high risk of colorectal cancer. And this is relevant for surgeons because it's important that we think about stratifying the risk so that we can screen in particular these patients appropriately. We can think about tailoring surgery, and we can also think about post-operative surveillance schedules. So if we go on to think about colorectal polyps, and again, mainly thinking about sporadic polyps, we can think about classifying colorectal or large bowel polyps in the following classification. So neoplastic, harmatomatous, inflammatory, serrated polyps, and then other or miscellaneous polyps. And the bulk of polyps are adenomas, sporadic adenomas, which may be solitary, or they may be multiple polyps, which don't necessarily mean that there is a defined genetic syndrome, such as FAP or MAP. Some people can have certainly more than one polyp in the absence of these defined genetic syndromes. We know that harmatomatous polyps may be juvenile polyps, Petzieger's polyps, and again, these genetic syndromes are associated with multiple polyposis. If we think about how polyps develop into cancers, now this is something where we do know a fair bit about the genetic variants that result in that. And if we focus on the left-hand side of the screen, we can see that if we're looking at normal epithelium, and we're just going to mainly focus on the adenoma to cancer pathway here, what we can see is that initially there are changes in the Wnt signaling pathway, followed by changes in MAPK signaling. These are all individual genes here that may carry variants, followed by mutations in SMAD4 signaling, PI3K signaling, TGF-beta, and then mutations in p53 tumor suppressor gene are in fact a late event in colorectal cancer development. But recognizing this adenoma carcinoma sequence certainly gives us multiple opportunities to try and understand the disease and to try and think about stratifying risk and to think about preventive strategies. So when we see a colorectal adenoma or a polyp using a colonoscope, we can think about, there are certain features that I'm not going to talk about today that make it more likely that a polyp is malignant, but certainly one of them is the size of the polyp. And we know that the majority of polyps are in fact less than 5 millimeters in size. We do know is that their malignant potential increases as they increase in size. So polyps that are over 2 centimeters in size, usually around 50% of them may be malignant. So what can we do about polyps is that we can remove polyps. Now, not all polyps will progress to becoming colorectal cancers. We know that around 30% of the population may have polyps, but then only 10 of these may progress to becoming a cancer. So we can undertake bowel screening and remove polyps if we see them. And in Scotland, this occurs every 2 years from the age of 50. It's using the quantitative fecal immunochemical test or QFIT test. And it's quite important to stress here that this is simply a test for blood in the stool. It's not a specific or a sensitive enough test for bowel cancer itself, so it cannot be used as a rule out, but it is the main screening tool used across the country and in several other countries. One thing just to say about bowel screening is that clearly where the threshold is set determines the yield in terms of neoplasia. So if we look at these graphs here we can see that hemoglobin per gram of feces is here. That as there's not much blood, it's likely to be normal, but actually as the amount of hemoglobin increases, there's more likely to be colorectal cancer. And so you can set your threshold at different levels, and this will give you some idea of how much colorectal cancer one may detect, how many advanced adenomas one may detect, and indeed prevent future cancers. In Scotland, the bowel screening cutoff is at 80. Since the introduction of QFIT, the uptake has increased, which is a good thing, and it's also increased in the more deprived areas. But it does have a greater positivity rate than the old test, which certainly means an increased burden on colonoscopy services. If we think about pathways to diagnosis of colorectal cancer, they can either be elective or emergency pathways. We may get referred patients from primary care who we then decide may have a colonoscopy, a CT colonogram, or be seen in outpatients, then have a cancer diagnosis, or they might come in through the bowel screening channel, or they might be in a high-risk syndrome screening, or indeed they might present as an emergency. And we know due to the pandemic that certainly a lot of our routes to colorectal cancer diagnosis have been curtailed. And why is it important? And when we look at the mode of presentation, just to draw your attention here, if we look at screening, the relative survival rates are greater in the group that are screen detected, for instance, compared to those that present with later stage disease as emergencies. So clinical presentation, and this is something that you'll all be familiar with, a change in bowel habit, PR bleeding, well, hopefully not yourselves, but abdominal pain, and then loss of appetite or unexplained weight loss. And then patients may present as an emergency with obstruction, perforation, bleeding, or localized pain. How do we investigate these patients? The starting point is always a good history and clinical examination, including a PR, a rigid sigmoidoscopy and biopsy of a rectal lesion if it's present, and then a CT, and then a colonoscopy or a CT colon. And it's quite important that all patients, even if they simply have a rectal cancer, undergo a full colonic investigation, because around 3% may have a synchronous lesion, which means a lesion, another cancer found at the same time. And if we look here, this is something that we don't really do anymore in terms of using barium enemas, but you can see a classical apple core lesion outlined by the barium here. When we think about staging of disease, there are several different types of staging: clinical staging, pathological staging, which combines clinical staging with the pathology, and then restaging when we're thinking about the extent of disease recurrence. And again, if we think about staging, all patients with colorectal cancer should have a CT of their chest, abdomen, and pelvis. The rectal cancers should have an MR scan. And then we might use a targeted ultrasound or MRI to look at the liver specifically, or a CT PET if we are considering exenterative surgery or trying to delineate the extent of recurrence. And here we can see that there's a rectal cancer sitting there, which again you can see here. Indeed, here in this, close to the splenic flexure, you can see another one of these apple core lesions. Again, staging, I can't stress enough the importance of a digital rectal examination for rectal cancers. Overall, this is really important because we're thinking about trying to manage patients as individuals, thinking about their future surveillance schedules, and staging all forms part of that, and indeed entry into clinical trials. The commonest staging is the tumor node metastasis staging that we use for staging colorectal cancer. And you can see that this is based on the T relates to the tumor itself. You can have T1 to T4, T1 going into the submucosa, T2 into the muscularis propria, but not through the muscularis propria. T3 goes beyond the muscularis propria, and T4 thereafter. The node staging is relatively straightforward, with N0 being no lymph node metastases, and then a series of divisions which relate to the number of lymph nodes. This can be put together, the TNM staging, to form AJCC staging, where we can look at these stages and compare them. And again, if we look at this data from CRUK, we can see stage 1 disease to stage 4 disease along the x-axis. We can see that there is a decrease in 5-year survival with increasing stage of disease. Now, there are several pathological prognostic features which are markers of an adverse outcome, things such as a signet ring cancer or an undifferentiated cancer, markers such as lymphatic invasion, vascular invasion, perineural invasion, or tumor budding. And again, these all form part of the pathological features that help staging. So we discuss all patients at an MDT, thinking about patients individually. And this comprises numerous members of the team, and we're thinking about whether there's a curative option for a patient, whether the patient is fit for surgery, whether they require some neoadjuvant treatment beforehand, and whether there's anything that may predict the response of these patients. The main principles of cancer surgery for primary disease are to remove the cancer itself with a negative resection margin or an R0 resection margin, to remove the lymph nodes, to minimize morbidity and mortality, and where one can, to restore anatomy or bowel continuity and reconstruct the bowel. Surgery really is the main, for non-disseminated disease, the main offer for a cure, and that may be resectional surgery, or it might be endoscopic resection for polyp cancers. In an emergency scenario, we may undertake a segmental excision. We may have to do a Hartmann's procedure where we can't join the bowel back together and the patient has a stoma. Or indeed, patients may undergo endoscopic combined with radiological palliative colonic stenting. And the elective scenarios are as follows, and it's really the blood supply that, to some extent, that determines the resection extent. So for right-sided cancers, might do a right hemicolectomy. With a cancer that's towards the distal part of the transverse colon, this patient might undergo an extended right hemicolectomy. Or for left-sided tumors, patients will undergo, it's probably a little bit more than this line, dotted line here, undergo an anterior resection, or indeed for a tumor that's involving the sphincters, an abdominoperineal resection. If we think briefly about recurrence, we go through the same pattern again. We think about restaging, whether there is a curative option, how likely are we to get a negative resection margin, is the patient fit for surgery, and is there any role of neoadjuvant treatment? And the principles are the same. We want to remove the recurrence with a negative margin and minimize morbidity and mortality. And these data here really shows that the resection margin is one of the key determinants of overall survival. So this R0 is a clear resection margin, and we can see that as there is an R1 or an R2 resection, we can see that survival declines. And patients where we're considering pelvic exenteration for recurrent rectal cancers, clearly patient selection is important because what we can see is that a third will have major complications, and we don't want to put patients through that unless they have a high chance of an improvement in their survival. I'll very briefly talk about adjuvant chemotherapy, just really to say that capecitabine is the mainstay of colorectal cancer primary adjuvant treatment. Capecitabine is converted to fluorouracil by the body, and you can see that it forms the mainstay of these different chemotherapy regimens. There are various second-line targeted agents which again target different receptors within cells and are not necessarily used as first-line agents. When there's an increasing focus on PD-1 inhibitors. Rectal cancer is, we don't consider colonic cancer for neoadjuvant radiotherapy, but rectal cancer may be considered either short course or long course, and I'm not going to go into the details here. The rationale for radiotherapy is really to try and decrease the local recurrence rate. And whilst this is decreased following neoadjuvant radiotherapy, there is no overall improvement in overall survival, but it can be utilized to downstage disease for advanced rectal cancers. And then thinking about palliation briefly, sometimes we do need to undertake surgery for patients where there is no chance of a cure, but we might need to try and control their symptoms, relieve obstruction, stop bleeding, again with the same aspects of trying to maximize their symptom control. I'm not going to talk about the genetic predisposition syndromes, other than really to say that we know that the lifetime risk for DNA mismatch repair mutation carriers is high in males, less so in females, but they also potentially have other cancers. And so these patients need to be in surveillance schedules that are regularly examining for colorectal cancer development. And again, FAP, which is due to germline mutation in APC, and there are several different mutations, and the location of the mutation impacts upon the type of phenotype patients have, but these are some of the diagnostic, or rather the mnemonic features with retinal pigmentation, duodenal polyps, osteomas, desmoid tumors. You can see multiple polyps carpeted here. And just say here really, and this is where one has to consider prophylaxis when we're thinking about risk-reducing surgery in these patients, whether they have developed a cancer or not. And in FAP, we would primarily consider a complete proctocolectomy and an ileoanal pouch. In some patients, we might consider a colectomy and an ileorectal anastomosis, and this has certain caveats attached to it, providing they have a low rectal polyp burden, depending upon the mutation site. Again, whether the patient is going to be compliant with coming for surveillance plays a role. In Lynch syndrome, they need to be in regular surveillance. We don't undertake prophylactic surgery, but if a patient does develop cancer, then we may consider an extended resection, a colectomy and an ileorectal. And in females, we may consider an abdominal hysterectomy and oophorectomy, again, for the females. Obviously, another risk factor is patients with long-standing ulcerative colitis or Crohn's colitis. And in patients with UC, we would consider a colectomy and ileoanal pouch, or indeed a colectomy and end ileostomy. I think what we may well do here is potentially stop, I think, Mark. I had a few more slides, but I know we're supposed to stop by about 4:30, is that right?
Yeah, no, that's right. That's been brilliant. That's been a very good overview. I had a couple of questions, but actually the audience have got a couple of questions which I hope you don't mind them asking. The first is, what's the significance of microsatellite instability in the management of colorectal cancer? I wonder if you'd be happy to just overview that for them.
Yeah, absolutely. Sorry, as I sort of said, is that, you know, we clearly wouldn't, I wasn't going to cover the sort of genetic aspect, but microsatellite instability occurs in those patients with mismatch repair mutations, but we can also see it, we can see microsatellite unstable cancers in patients without obvious mutations, and this certainly does have a role in terms of their adjuvant chemotherapy regimens. And certainly what we would do, and nationally what patients do, what the departments do is mismatch repair testing in the form of, usually in the form of immunotesting to try and establish whether these patients are microsatellite stable or unstable, with a view to then seeing whether they would be candidates for chemotherapy or not, depending upon the stage of disease.
Okay, that's brilliant. And then I suppose one other question which a couple of people have raised with regards to FIT testing, and how's COVID affected FIT testing? How are we dealing with the delays? Are we getting back to normal? And I suppose going on from that, what's your feeling about increasing the FIT testing for younger people, given that that's where there's an increasing prevalence in cancer?
Okay, so there's about 5 questions, Mark, thanks. So firstly, I mean, so COVID itself hasn't affected FIT, but whereas in some places I think it's already been used in primary care as an adjunct to triaging patients, if anything, what COVID has done is sort of accelerated the use of QFIT in primary care and in secondary care, and really trying to triage out patients to get the patients most likely to have pathology to an investigation, whilst we're in a sort of state where we have decreased access to investigations, whether that be colonoscopies or CT colonograms. And certainly I've seen sort of lots of different strategies being trialed around the country. I think the main thing that I would emphasize is that it certainly isn't a rule out for cancer, the sensitivity of the test, and we've looked at a large data set in Lothian, and the sensitivity remains at around sort of 82%. So one has to have a safety netting and risk mitigation strategy. Certainly what we did over this period was use QFIT to try and enrich for pathology, and our cancer detection rate in those patients that were referred has remained the same, showing that the strategy worked. But in fact, our number of referrals was decreased by around 50%. So there's a real concern that we share with others around the country that we are going to see an increase in emergency presentation of patients in some months to come. Yeah, no, and that seems to be our experience here in Oxford as well, is that we're now using QFIT to help us fight the backlog of colonoscopies we need to get done. But as you rightly said, there is that worry that we're missing a whole group that are testing negative but still have cancer. Yeah, or indeed still have symptoms. And so it's like with anything, the kind of entry strategy is easy. It's the exit strategy of, you know, the patient with 2 not detected QFITs, but is still quite symptomatic.
Yeah, no, indeed. I mean, that covers everything. I haven't got any other questions. I think you've covered the topic of colorectal cancer, which is a big, broad topic and very important to general surgeons. And so I thank you on behalf of everybody for the time you've given us. I would just like to say that we have another session in 2 days' time on incisional hernia repair and sort of the principles of repairs. So hopefully you can all join us for that, and may we all thank Miss Din for her time and a very informative talk. Thank you. Thanks very much.